Hello and welcome to yet another module on physical education. Today we are discussing about the various body joints and the practical techniques of discovering whether these joints are in fully functional condition or there are some problems in them or there are some deformities. In examining the musculoskeletal system, it is important to keep the concept of function in mind. Note any gross abnormalities of the mechanical functioning, beginning with the initial introduction to the patient. Continue to observe for such problems throughout the interview and the examination. On a screening examination of a patient who has no musculoskeletal complaints and in whom no gross abnormalities have been noted in the interview and general physical examination, it is adequate to inspect the extremities and trunk for observable abnormalities and to ask the patient to perform a complete active range of motion with each joint or set of joints. If the patient presents complaints in the musculoskeletal system or if any abnormality has been observed, it is important to do a thorough musculoskeletal examination, not only to delineate the extent of gross abnormalities, but also to look closely for subtle anomalies. To perform an examination of the muscles, bones, and joints, use the classic techniques of inspection, palpation, and manipulation. Start by dividing the musculoskeletal system into functional parts. With practice, the examiner will establish an order of approach, but for the beginner, it is perhaps better to begin distally with the upper extremity, working proximally through the shoulder, then beginning with the temporomandibular joint, pass on to the cervical spine, thoracic spine, the lumbar and sacroiliac joints. Finally, in the lower extremity, again begin distally with the foot and proceed proximally through the hip. Use the opposite side for comparisons. It is easier to spot subtle differences as well as identify symmetrical problems. If there is any question, use your own anatomy as a control. Glean the maximum information from the observation. Concentrating on one area at a time, inspect the area for discoloration, that is, ecchymosis or redness, soft tissue swelling, bony enlargement, wasting and deformity, abnormal angulation or subluxation. While noting these changes, attempt to determine whether these are limited to the joint or whether they involve the surrounding structures, example tendons, muscles, or bursae. Observe the patient's eye while palpating the joints and the surrounding structures. A patient's expression of pain depends on many factors. For this reason, the verbalization of pain often does not correlate directly with the magnitude of the pain. The most objective indicator of the magnitude of tenderness produced by presence on palpation is involuntary muscle movements about the eyes. Therefore, the examiner should observe the patient's eye while palpating the joints and surrounding structures. With practice, the examiner will become skilled in evaluating the magnitude of pain produced by examination and will be able to do a skillful evaluation without producing excessive discomfort to the patient. Note areas of tenderness to pressure and, if possible, identify the anatomic structures over which the tenderness is localized. One should also note areas of enlargement while palpating the joints and surrounding structures. By noting carefully the consistency of the enlargement and its boundaries, one can decide whether this is due to bony widening, thickening of the synovial lining of the joint, soft tissue swelling of the structure surrounding the joint, and effusion into the joint capsule, or nodule formation, which might be located in a tendon sheath, subcutaneous tissue, or other structures about the joint. While palpating the joints, note areas of increased warmth. A method for doing this that will help even the most inexperienced to perceive subtle increases in heat is to choose the most heat sensitive portion of the hand, usually the dorsum of fingers, and beginning proximally, lightly pass this part of your hand over all portions of the patient's extremities several times. As you proceed from proximal to distal, the skin temperature gradually cools. If you find an area becoming slightly warmer, this represents increased heat. Have the patient perform active movements through an entire range of motion for each joint. Defects in function can be most rapidly perceived by having the patient perform active functions with each region of the musculoskeletal system. This reduces examination time and helps the examiner to identify areas in which there is poor function for more careful evaluation. Manipulate the joint through a passive range of motion only if the patient is unable actively to perform a full range of motion or if there is obvious pain on active motion. In passively manipulating a joint, note whether there is a reduction in the range of motion, whether there is a pain on motion, and whether crepitus is produced when the joint is moved. Note also whether the joint is stable or whether abnormal movements may be produced. Musculoskeletal disorders are the commonest cause of disability. Each year, 15% of patients on a general practitioner's list will consult their doctor with a locomotor problem, and such conditions form 20 to 25% of a GP's workload. About 30% of those with any physical disability and 60% of those with a severe disability have a musculoskeletal disorder as the primary cause of their problems. Clinical skills, that is, competent history taking and examination, are the key to making an accurate diagnosis and assessment of a patient complaining of joint problems. Arthritis is a term that is frequently used to describe any joint disorder and not infrequently any musculoskeletal problem. It could be argued that the term arthritis should be used to describe inflammatory disorders of the joint, whilst arthropathy should be used to describe non-inflammatory disorders. Other musculoskeletal problems should similarly be described according to their anatomical site, example muscle or tendon, and whether they are of inflammatory or non-inflammatory etiology. However, the term arthritis is in such widespread general use to describe any disorder of the joint that for the purpose of this module it will be used in that sense. There are over 200 different types of arthritis, both inflammatory and non-inflammatory. And in general, it is not necessary for a practicing clinician to know about all of these. A more realistic approach is to adopt a classification scheme and to learn how to place patients' problems within this classification using information gained through a full history and examination. The five key questions which need to be answered are: does the problem arise from the joint, tendon, or muscle? Is the condition acute or chronic? Is the condition inflammatory or non-inflammatory? What is the pattern of the affected areas or joints? What is the impact of the condition on the patient's life? The answers to these questions should enable you to produce a succinct summary of the patient's condition. For example, of a patient's summary produced using this method might be: this patient has a chronic symmetrical inflammatory polyarthritis mainly affecting the small joints of the hands and feet, which is causing pain, difficulty with dressing and hygiene, and is limiting her mobility. A brief screening examination, which take 1 to 2 minutes, has been devised for use in routine clinical assessment. This has been shown to be highly sensitive in detecting significant abnormalities of the musculoskeletal system. It involves inspecting carefully for joint swelling and abnormal posture, as well as assessing the joints for normal movement. This screening examination is known by the acronym GALS, which stands for gait, arms, legs, and spine. The sequence in which these four elements are assessed can be varied in practice. It is usually more convenient to complete the elements for which the patient is weight bearing before asking the patient to climb onto the couch. Now let's talk about gait. Ask the patient to walk a few steps, turn and walk back. Observe the patient's gait for symmetry, smoothness, and the ability to turn quickly. With the patient standing in the anatomical position, observe from behind, from the side, and from in front for bulk and symmetry of the shoulder, gluteal, quadriceps and calf muscles, limb alignment, alignment of the spine, equal level of the iliac crests, ability to fully extend the elbows and knees, popliteal swelling, abnormalities in the feet such as excessively high or low arch profile, clawing, retraction of the toes, and or presence of hallux valgus. Arms. Ask the patient to put up their hands behind their head. Assess shoulder abduction and external rotation and elbow flexion. These are often the first movements to be affected by shoulder problems. With the patient's hands held out, palms down, fingers outstretched, observe the backs of the hand for joint swelling and deformity. Ask the patient to turn their hands over. Look at the palms for muscle bulk and for any visual sign of abnormality. Ask the patient to make a fist. Visually assess power grip, hand and wrist function, and range of movements in the fingers. Ask the patient to squeeze your fingers. Assess grip strength. Ask the patient to bring each finger in turn to meet the thumb. Assess fine precision pinch. This is important functionally. Gently squeeze across the metacarpophalangeal MCP joints to check for tenderness, suggesting inflammatory joint disease. Be sure to watch the patient's face for non-verbal signs of discomfort. Legs. With the patient lying on the couch, assess full flexion and extension of both knees, feeling for crepitus. With the hip and knee flexed to 90 degrees, hold the knee and ankle to guide the movement. Assess internal rotation of each hip in flexion. This is often the first movement affected by hip problems. Perform a patellar tap to check for a knee effusion. Slide your hand down the thigh, pushing down over the suprapatellar pouch so that any effusion is forced behind the patella. When you reach the upper pole of the patella, keep your hands there and maintain pressure. Use 2 or 3 fingers of the other hands to push the patella down gently. Does it bounce and tap? This indicates the presence of an effusion. From the end of the couch, inspect the feet for swelling, deformity, and callosities on the soles. Squeeze across the metatarsophalangeal, that is MTP joints, to check for tenderness, suggesting inflammatory joint disease. Be sure to watch the patient's face for signs of discomfort. Now spine. With the patient standing, inspect the spine from behind for evidence of scoliosis and from side for abnormal lordosis or kyphosis. Ask the patient to tilt their head to each side, bringing the ear towards the shoulder. Assess lateral flexion of the neck. This is sensitive in the detection of early neck problems. Ask the patient to bend to touch their toes. This movement is important functionally for dressing but can be achieved relying on good hip flexion. So it is important to palpate for normal movement of the vertebrae. Assess lumbar spine flexion by placing 2 or 3 fingers on the lumbar vertebrae. Your fingers should move apart on flexion and back together on extension. Recording the findings from the screening examination, that is GALS. It is important to record both positive and negative findings in the notes. The presence or absence of changes in appearance or movement in the gait, arms, legs, or spine should be noted in a grid. If there are abnormalities, these should be recorded with a cross and a note should be made describing the abnormalities. For a patient with wrist and knee swelling and associated loss of movement, the recording might be as shown. If you have been alerted to a musculoskeletal problem by the screening questions, your examination or spontaneous complaints of the patient, you will need to take a detailed history. You should also conduct a regional examination of relevant joints. This is described in the sections which follows. GALS screening examination checklist. Gait. Observe gait. Observe patient in anatomical position. Arms. Observe movement, hands behind head. Observe backs of hands and wrists. Observe palms. Assess power grip and strength. Assess fine precision pinch. Squeeze MCPJs. Legs. Assess full flexion and extension. Assess internal rotation of hips. Perform patellar tap. Inspect feet. Squeeze MTPJs. Spine. Inspect spine. Assess lateral flexion of neck. Assess lumbar spine movement. In examining the musculoskeletal musculoskeletal system, it is important to keep the concept of function in mind. Note any gross abnormalities of the mechanical functioning, beginning with the initial introduction to the patient. Continue to observe for such problems throughout the interview and the examination. On a screening examination of a patient who has no musculoskeletal complaints and in whom no gross abnormalities have been noted in the interview and general physical examination, it is adequate to inspect the extremities and trunk for observable abnormalities and to ask the patient to perform a complete active range of motion with each joint or set of joints. If the patient presents complaints in the musculoskeletal system or if any abnormality has been observed, it is important to do a thorough musculoskeletal examination, not only to delineate the extent of gross abnormalities but also to look closely for subtle anomalies. To perform an examination of the muscles, bones, and joints, use the classic techniques of inspection, palpation, and manipulation. Start by dividing the musculoskeletal system into functional parts. With practice, the examiner will establish an order of approach, but for the beginner, it is perhaps better to begin distally with the upper extremity, working proximally through the shoulder. So in this episode, we have discussed a very visual description, a very practical description of the various body joints and their movement and any kind of problems or deformities that might be found in them. So this information, I hope, will be useful to all of you. Thank you so much for watching.